All right, good day, everybody. Thank you so much for joining this meeting. It's a webinar, a special one in that way, talking about the evaluation of anorectal anatomy using a 3D endoluminal ultrasound scan. Our speaker is Professor Nina Yoo from Korea, and she's gladly and kindly joined, even though there's a large time difference between where we are and where she is. And so we're very grateful that she sacrificed this time to give us this talk. So because of that, we will not waste time with too many formalities, but I'd like to hand over to Dr. Ulasi to read out her brief bio to introduce her before she starts. Dr. Ulasi, the floor is yours.
Thank you so much, Dr. Day. It's my pleasure to read a brief citation of Professor Nina Yoo. She had her bachelor in 2004. After that, she proceeded to get her MD at the Chumbok National University Medical School in Korea. She obtained her PhD at the Catholic University of Korea in 2020 in terms of her medical center in Korea, and then completed her residency in general surgery in 2015 at the same institution. Between 2015 and 2017, she did her fellowship in the Division of Colorectal Surgery at St. Vincent's Hospital, the Catholic University of Korea. She became the clinical assistant professor in the Division of Colorectal Surgery at St. Mary's Hospital. And between 2024 and 2025, she was a clinical assistant professor in the Division of Colorectal Surgery at St. Vincent's Hospital, assistant professor in the Division of Colorectal Surgery at St. Vincent's Hospital, so on. And she's a leading figure and a key member of the Committee on International Relations of the Korean Society for Colorectal, and she's played a very key role in the discussions that provided opportunity for us to have fellowship opportunities for our members to Korea. And Dr. Nina, please.
Thank you. Thank you for inviting me as a speaker today. I'm Nina Yoo from the Catholic University of Korea. I am a colorectal surgeon, and I'm really honored to get to speak something about the use of transrectal and transanal ultrasound in anorectal disease and evaluating the anorectal anatomy today. Well, I will start to show you the ultrasound machine. This is how the machine looks like. Well, transrectal or transanal ultrasound is a widely used imaging technique to visualize the anatomic structures of the rectum and the anal canal and pelvic floor using the ultrasound. It has really good resolution, and you can visualize submillimeter structures. It also allows real-time scanning, so the operator can control what, when, and where, and how to look at the anorectal disease and the anorectal anatomy. Nowadays, I used to scan in 2D scan system, but it's offered in 3D system now. It's really quick and easy, and you can get really clear image with pelvic anatomy and sphincter structures. What you will be looking at is these area in sagittal view. Sagittal view, you can look at the whole structure around here. Well, once you get into the anal canal with the probe, you can go up to about the pelvic reflection area, and this is probably the top area where you can see the sacrum in the posterior, and above the pelvic reflection, you can see the small bowel. Well, this is the sample video. The transrectal ultrasound can visualize the entire pelvic floor and pelvic cavity and the pelvic organs. And while the transanal ultrasound focuses on visualizing the anal canal system. This is how you scan through the whole anatomy. First, transrectal ultrasound can be used for rectal cancer staging. It has pretty accurate. It has high accurate diagnostic system for cancer staging. Rectal wall layers can be distinguished using the when the transducer is introduced into the distended rectum. This is how you distend the rectum. You use the water balloon system and you fill up the rectum with the water and distend the whole layer. This is the example of the LSD. When you look at the LSD and the endoscope, you scan through the rectum. Once you fill up the rectum with the balloon with the water, and you can move around, and you can see it's located right here. And you can see that the tumor is limited in the mucosal layer, not penetrating the submucosa. You can actually see the entire rectal wall layers. It has even better resolution than MRI. And this is another example. When you look at the tumor at the edge of the anal verge, it's located at the inferior Houston belt. And when you look at through the ultrasound, it's right here. In front of it, the seminal vesicle is in front, and the tumor is located just right behind the seminal vesicle. Another example is you can see this bulky tumor on the endoscope, and when you scan through the rectum using the ultrasound, you can see that the tumor is involving the entire rectal wall layer, and can actually move around and scan it through. You can see that the mass involves more than 1/2 of the lumen and invades the prostate. Well, this is another example. Here you can see submucosal tumor, and in the mid-rectum, you can see that the mass is located just right here within the submucosa layer, right here. Well, you can see where the tumor is located, and you can evaluate it in detail. Well, you can actually locate and where the tumor is located, especially in the disc rectum, and you can see each structure where the sphincter is located, where the pelvic floor is located, and especially in males, you can see the prostate and vagina in female, and pelvic floor muscle in details. Well, for even more, in the distal rectum, the mid-rectal vessels are usually not very visible in other imaging modalities like MRI or CT scan, but in ultrasound, the mid-rectal vessels can be identified easily. Clinical implication of this imaging technique is highly significant because it can provide insights into the potentials for distant metastasis or nodal metastasis. Well, so far I've talked about how the transrectal ultrasound is good for rectal cancer diagnosis. Now, moving on to the transanal ultrasound. Well, this is an example of 3D scan by transanal ultrasound. As the transducer scans through the anal canal, you can get the detailed information, and the patient is positioned in the left lateral decubitus position, and as the patient as we put the probe inside the anus, you can get the same position as the patient is lying down. Anterior on the right side, posterior on the left side, right and left, or you can actually rotate it. It depends, it's up to you. You can actually decide how you look at it. This is the anatomy you can get the information from. The anal canal is divided into three parts, upper, mid, and distal. And when you look at the sonographic anatomy, you can get the details of each segment of the anal canal. What you need to remember is just that the smooth muscle appears the low intensity, just the black color, and the skeletal muscle appears with higher intensity, showing hyper echogenicity or mixed echogenicity. Here, you can see the view of each muscles. Here, this is the internal sphincter. You can see the puborectalis muscle and deep external sphincter here. And you can actually see the longitudinal muscle as well. And as the internal muscle stops right below it, you can see the external sphincter, subcutaneous external sphincter muscles. This is how the anal canal looks like in normal people. This is the actual view of the three segments. Well, in the upper anal canal, you can see the puborectalis muscle, and in the mid anal canal, you can see the very black circle of the internal sphincter and external sphincter surrounding it. And just below distal anal canal, you can see the subcutaneous external sphincter with a mixed echogenicity. Well, I'll show you the spaces as well. You can actually define these spaces using all those sphincter structures. Here, a lot of you will probably know where these the abscesses can occur, like the supralevator abscess and rectal abscess and intersphincteric abscesses. These spaces are potential spaces for the abscess. I'll show you a few examples of how an abscess appears in the transanal ultrasound. First, this is the intersphincteric abscess. I think there was something wrong. It's not scanning. The video is not playing. Can I show
No,
you? Can I
not playing.
share? It's
Yeah,
not playing, right?
not playing.
Okay, hold on one second. Let me see. I'm sorry for the interruption. Well,
No worries.
I can show you. I'm trying to open up other file that plays.
Okay.
Sorry. Well, sorry for the interruption. I can get some questions
Oh,
while you guys are reading.
all right.
Sorry.
No worries. Well, we'll wait for the video to come up. The question I wanted to ask is, what are the specs for the ultrasound scan that can do this? Is there a specific model that we should look at for? And I'm sure people will be interested in that. And then secondly, what's the learning curve like to be able to do it? Especially if you just consider the fact that a trainee who has never handled an ultrasound probe before, wants to start doing this. How many cases does that person need to do to be confident to give some form of interpretation of the images?
Well, it doesn't take that long of cases. Maybe 60s. You can actually get it. You can actually get the understanding. You just need to know the anatomy of the anal canal, and if you have if you have full grasp of the anatomy, you can actually learn it really quick. You don't have to worry. The the longer you look at it, the more cases you encounter, you will get it right away.
Yeah. Do you have the video?
Yeah.
Do you have the video up or
Well,
should you have
yeah,
it?
the video will play now.
All right, good.
Okay, here. Now you see here there's a the abscess. The abscess is located right here. You can see that. Do you see my pointer?
Yes.
Yeah. Okay. It's right here. You can actually see that it's in between the internal sphincter and external sphincter, and it's located uh, right here. Do you see it?
Yes, we do.
Yeah. Well, you notice that there's a hypoechogenic abscess in between the sphincter muscles, located very superficially. So, simple IND will handle the patient. Well, this is an example of a superficial post-anal abscess here. Well, it's not playing again. Something happened.
No worries. Can you bring up the video or not?
I don't know why it's not keep on playing videos. I'm so sorry. Okay.
Yeah, no need to apologize.
Okay. Now it's working.
Great.
Yeah. Okay. Sorry for the interruption, guys. Here you can see the superficial postanal abscess located at 6 o'clock. You can see the large internal opening at 6 o'clock in direction here. The abscess extends into the deep postanal space here. You see that? There's an internal opening here, and the abscess is extending right here, right above the deep postanal space. Here's another example of a horseshoe abscess. Wow, it's keep on not playing. I don't know why, but okay, okay, great. Okay, see.
Yeah, I saw the horseshoe shape.
Yeah, it's playing now.
Yeah,
Okay. The abscess cavity is formed. The abscess cavity forms a horseshoe shape surrounding the mid to upper anal canal. You can see the internal opening, right? You just passed it at 6 to 7 o'clock
yeah.
in direction. Yeah. Okay. Now moving on to the next. Well, this is an example of a deep postanal abscess extending to the supralevator space. Well, above the pelvic floor muscle, the abscess is extending. You can see this really big hypoechoic abscess cavity from 6 to 8 o'clock in direction. And on coronal view, you can see that it extends up to the supralevator space. Here. Yeah. Okay. Now, sometimes the abscess can occur in the submucosa of the distal rectum. You can see the oval-shaped abscess cavity at 2 to 3 o'clock in direction in submucosa of the distal rectum. Here. Well, this is an example of a supralevator abscess. Okay. You can see there is a large abscess cavity above the puborectalis muscle. So if you understand the anatomy of the pelvic floor and a canal, yeah, the identification of anorectal disease becomes really simple. Besides the abscess, you can also diagnose fistula. Well, if you consider abscess is an acute form of an infection, fistula is a chronic infection. So chronic infection can create abnormal communication between the anorectal tract and the perianal skin, and also the fistula can be named by the path that the tract courses through. I'll show you a few examples. Like this is an example of the intersphincter fistula. It's located in the posterior area. As you see, this is without the enhancement. You can actually use H2O2. You can inject H2O2 at the external opening, and you can see here the fistula tract is visualized right here. And you can decide how to treat, what type of surgery you do for each the different types of fistula. This is hold on. This is the capture demonstrating an intersphincter fistula with hydrogen peroxide enhancement. This is an example of a transsphincteric type of fistula. The external opening was at 3 o'clock in direction. The fistula tract can be traced with hydrogen peroxide. As you can see, it penetrates the external sphincter posteriorly, going up to the mid-anal canal. The internal opening is located at 6 o'clock. So it's really good example of a posterior fistula tract being the Goodell's rule. Here's another example of a sphincter type of fistula. This fistula tract is thicker and penetrates high up in the anal canal. With the sonographic appearance, the fistula tract, you can predict how much sphincter is involved and how much damage can occur when you perform surgical excision. So you probably need to do a sphincter preserving surgery for these type of fistula. This is a good example of a sphincter type of fistula. Involves a large amount of sphincter muscles.
Hello, Professor Nina. Sorry to interrupt. Is it possible to hover your cursor over the place you are discussing so that people can follow?
Huh?
Is it possible to use the pointer?
A pointer?
Yes, to just show.
I just figured that once I start using the pointer, the video is not playing.
I see.
Yeah, that's why. Sorry.
Okay, it's fine.
Do you see my mouse?
Yes, we can see it. We can see this now.
Yeah, you can see the mouse?
Yes.
Okay,
so maybe you could use this, yeah.
Yeah, I can use the mouse.
Yeah, thank you.
Sure. Sorry. Well, that was it. I showed you many examples, simple examples. Well, as you saw, I don't know if you catched all the pictures and videos, but 3D endoluminal ultrasound is quite a valuable method to assess the anatomy of the rectum and anus. And if you don't have MRI, ultrasound is a good option. If you have those machine, but uh, to apply those machine, you just need to have the full understanding of the anorectal anatomy to avoid accurate assessment. And if you are interested in learning ultrasound and endoscopy, you can come. I I can offer you a free training system. Um, doesn't take you that long, maybe for about a month or maybe experiencing about 60 cases. You can fully understand the anatomy and also diagnose. Um, takes takes about 1 to 3 months if you fully commit yourself to understand and to get fully trained using the ultrasound. Well, if you have any questions, I can answer you.
Yes. Thank you, Nina, for this very brilliant presentation. We're really very grateful for this. Um, I know the time is fast spent where you are, so we'll quickly address the questions that we have for you. So there are some questions in the chat. I'll read out to you so that you can attend to them. And then anyone who has a question can raise their hands, and then I would bring them up stage to ask Nina the question. So there's one question saying that does the rectum have to be filled with water or fluid to use the device?
I didn't understand. What did he say?
He said that does the rectum have to be filled with water or with fluid to create an interface to also you can identify lesions more readily?
So the rectum should get filled up with water
Yes,
with a
that's
balloon.
yeah, okay. Yeah. And then there's another question saying that is there a difference between using a balloon filled with water and a sheet filled with gel in the inner ultrasound?
Oh, you can use the gel, but it will be harder because there, as I showed you the shape of the rectum. Let me show you here. You can
Yes.
see the rectum has different volumes. In the upper portion, you will require more water, about 80 milliliter of water to fully extend to fully distend the rectum in male, but in female, probably 100 or 120 if female has larger pelvic cavity. But once you get the lower part of the rectum, you need to get rid of water to visualize the distal rectum and the anal canal. As you can see, it has the acute narrowing of the anal rectal junction. So once you scan through the rectum, you can only scan 6 centimeters per segment so you have to get rid of the water. You have to get rid of the fluid, whatever the fluid you're using to distend the rectum. Well, if you use a gel, it will be harder for you to get rid of the fluid.
Yeah,
And it'll be harder for you to evaluate the lower part of the rectum.
yeah, makes sense. So the
Yes.
next question is can you use the truss to sufficiently have a T and N staging for low and mid rectal cancers?
Well, can you repeat the question?
Can you use the trust to stage for the T and the N staging for low and mid rectal cancers?
T staging and N staging.
Yeah, T staging and N staging for mid and
Okay.
rectal cancers.
So, well, here, this is the key image. Once the probe is located within the rectum, you fill up the balloon, and there's a balloon interface. As the balloon interface shows up white, and the mucosa will show you black, and the submucosa will show you white, and muscularis propria will show you black. So you need to find each layer, and as the tumor is located within the submucosa, you will definitely know that it's T1. And as soon as it penetrates the muscularis propria, it's T2. And if it breaks the muscle layer and penetrates into the perirectal fat layer, then it's definitely T3. And the node, so here, this is an example. Well, it's right here. The LST is located within the submucosa. It doesn't come out. It doesn't penetrate, or it doesn't even touches the muscle layer. So it's definitely, you'll know that it's within the submucosal layer. And that's, you can evaluate you can actually use these layers to define the T stage. The next example, like this here.
Yeah.
Here, the tumor is located right here,
Yes.
and it's right at the muscle layer.
Yes.
Yeah, and the node. This is the seminal vesicle. The tumor starts at the seminal vesicle, and here you just sorry. As you see here, you see
Yes.
this little
Lymph node.
lymph nodes.
Yeah.
You can see these tubular structures running through the mesorectal area, and the tumor is involving the whole lumen of the rectum, and it's actually building to, or even infiltrating the seminal prostate right here. So you know that it's T4 tumor, and the lymph node, perirectal lymph node, is located right here.
Yeah.
So you know that it's N positive tumor.
Yeah. Very clear. Thank you so much. The next question is actually an extension of what you just mentioned now. Just asking whether you could use this ultrasound scan to assess the lateral pelvic side wall, or
No, actually, no. You can't see the lateral pelvic side wall lymph nodes. What you can see is if the lymph node is located, I'll show you one example. If the lymph node is located on lateral pelvic side wall, you can actually visualize. You can't. But if the lymph node is located right in the right next to the prostate, right next to the prostate, where 10 o'clock to 2 o'clock, where there's a pelvic plexus is located. If there's a tumor, if there's a lymph node metastasis, well, that's the key metastatic area. Probably that's the gateway of the nodal metastases to the lateral pelvic side wall. If there's a node around this area, you can't. Yeah. But like the obturator node or internal iliac node, those you can't.
Thank you so much. The other question was, could this help to determine the CRM status and EMVI status?
Yes, I think yes. EMVI, for example, the reason why I showed you the mid-rectal vessels like this, if the tumor is here, you just passed. This is the lymph node.
Yeah.
And that's the tumor.
Yes.
And if the tumor has a feeding vessels, like here, I just passed it. You can see the feeding vessel of the tumor.
Yes.
Here, you just passed it. If there's a feeding vessel, you can see, yeah, I mean, I usually call it, it's a EMVI. And what I just showed you here.
Okay. Yeah.
That's the mid-rectal vessel on one side.
Yes.
And all these, that's another feeding vessel. So if those vessels are present, then I usually call it EMVI positive. And if there's all these little irregular shaped without clear demarcation, those are probably, I call it tumor deposits.
Okay. Very nice. So I'll read the last question on the chat and then attend to the hands that have been raised. I want to ask verbal questions. So the last question on the chat is asking if you could suggest alternatives to the BK system machines, because these may be too expensive for our own resource constraint setting.
Well, as far as I know, BK system has the only BK system is the only 3D machine, and other like GE or Samsung, some other companies, they don't have 3D system yet, unfortunately. But with 2D system, you can actually make these images. They don't. The problem is they don't have the continuous probe, the ring probe. That's the only problem. Because the 3D reconstruct is available only in BK system. That's what I know.
Thank you for that. That's quite clear. So I can see one hand raised from Professor Emeka Reofo. I'll invite him to the stage shortly. But just as a quick announcement, after this presentation, please hang around because Dr. Olasi will be presenting his experience from his just concluded fellowship to South Korea. And before this meeting started, we actually did speak with our guest regarding how to move this forward, especially with our female colleagues on the platform. So please hang around so that we can discuss this after she's left. So the floor is left for you, Professor Reofo. Over to you, sir.
Thank you, President Ademola. Thank you, Dr. Nina, for this very interesting presentation.
Oh, you're welcome. My
Thank
pleasure.
you. Yeah. I wanted to glimpse an insight to the practice in Korea by asking what the Korean guideline for staging of rectal cancer, where do they have EUS in the guideline? Or what specific role does it play in the guideline? It's good to have that understanding because it gives clarity to the technology. Generally, these are all tools in the surgeon's armamentarium, like for the anal, comparing it to EUA gives it clarity. I mean, is less invasive and less traumatic, and then what the literature has regarding that comparison. And then for rectal cancer staging, where MRI is the gold standard for imaging, it will be interesting to know that's from you firsthand in this presentation, what the advantages and disadvantages and all of that. You started a bit, you said a bit of it in answering one of the questions, but I think it would be nice to have that clarity from this presentation, adding it to the novelty it offers. Thank you very much.
Well, so summarizing your question, in guideline, well, transrectal ultrasound can be used to evaluate the rectal cancer, but in conjunction with the MRI. I usually use transrectal ultrasound on especially when the patient has very low distal cancer in the rectum before surgery, whether to do the sphincter preserving or APR in dose setting, and whether I need to do pelvic centration. If the cancer is located to low in the distal rectum, it penetrates the adjacent organs like vagina or prostate. Too much of a pelvic floor, then I have to do the more extended surgery. Compared to MRI, it's more. It gives me, well, in several ways. It gives a lot more advantage. In MRI, I use the big picture, whether the patient needs to get TNT or CRT or surgery first. In conjunction with the addition of MRI, I decide. It gives me more idea, a better idea on how to operate the patient. And also, I spend more time with the patient, and I actually perform the transrectal ultrasound by myself and interact with the patient and discuss how the patient feels with the surgery, and whether the patient has better function or poor function of the sphincter, then even if I can perform sphincter preserving surgery, I sometimes decide not to preserve the sphincter. So yeah. I don't know if I gave you I don't know if I I give you the answer for what you asked, but
Yes, you did. I was eager to know if, in comparison to the 2D endorectal ultrasound, that the availability of 3D in your system I wanted to find out if that has displaced the role of MRI in your system. And then in the course of it, you've clearly shared that they are complementary, kind of, and
yes.
yeah. So thanks. It gives a lot of clarity. Thank you so much.
Oh,
Thank you so much, Nina. Again, I'm very grateful. We're all very grateful for this presentation. You showed me a lot of these things when I was in South Korea, and to see them again, it's quite great. I do have some questions for you, but I'll send them to you offline regarding my PhD research on rectal cancers and how I can incorporate this into care.
yeah.
Yeah.
Anytime.
So
Yeah.
I'll send them to you so that we can have a chat offline.
Okay.
Well, again, we are very, very grateful for the time you spent. So I don't think we can entertain any more questions again since you have to leave. So we are happy to excuse you so that Dr. Ulasi can have his presentation on his experience in South Korea. Thank you so much, Mark.
Thank you. Thank you for the invitation, Paul. It was my great pleasure to give you guys to get invited and give us a talk on my experience. If you are interested in visiting my country, you can actually come and contact me anytime. And yeah, I can show you Korea and share well get some experience on Korea by get some experience in Korea.
Thank you very much.
Thank you.
Yeah. So you can stop sharing your screen now. Dr. Ulasi.
Okay.
Thank you so much, Professor Nina.
Okay. So I'll see you guys later.
Yeah. See
It's
you.
all good to meet you online.
Yes. Thank you.
Thank you. I will
You stop sharing now. Okay, thank you.
Okay, great. Thank you.
Thank you very much.
Thank you so much.
Bye.
Bye.
So Dr. Lassie will be presenting his experience in South Korea. We really want to use it to turbocharge our plans for scholarship and then fellowships for our members this year. So I'll hand over the platform to him for him to make his presentation. He has proposed that it will be brief and straight to the point. Thank you.
Thank you, Mr. President. Can you see my slide?
Yes.
Okay, thank you. Good afternoon, everyone. It's my pleasure to discuss my experience in Korea last year. First, I want to appreciate the leadership of the Nigerian Society for Colorectal Disorders for their efforts in making the fellowship training a reality. It started with the immediate past president, Dr. Dimo, who had attended a conference in Italy sometime in 2024, early 2024, where he networked with some other participants, and that led to the invitation of our society to Korea later that year, where our current president, Dr. had discussions with the Koreans that eventually led to me having the opportunity to be there last year. So for my journey in Korea, it started with me having to process my visa. I had to send documents to the Korean people to help with registering me at the training institution, and also to be able to process the invitation letter that I used to apply at the Korean embassy in Nigeria. I had to go to that embassy a couple of times in Ikoyi, maybe 4 to 6 times. It was relatively easy, and just some drawbacks once in a while, but relatively easy. The Koreans are nice. They were able to, through mails, each time you complained, they responded and sorted out things that I needed to get the visa. I had a contact in Korea, Professor Jin Park. He was quite helpful from the preparatory stages to throughout my stay in Korea. In terms of sorting things out, he assigned me to a fellow, a Korean fellow in colorectal surgery that was giving me information, providing documents I needed, and linked me up with the admin officer in charge of accommodation. And then, of course, I needed to also look for funds. Mainly, I spent money on accommodation, flight, upkeep, and then visa. What took most of the money was on accommodation and my upkeep. But these two major areas, I must say that I'm very grateful to Professor Jin-Soo Park, who also subsidized all these things significantly for me when I got to Korea eventually. So this was my first, I arrived in Korea on the 13th of July last year, and the next day, Dr. Jin-Soo Park brought me to the hospital, introduced me to the members of the colorectal surgery unit, and from there, we headed to the operating room. They gave me a very comfortable apartment in this building here, where they use this building for international fellows and all visiting doctors. They had all the basic things that one needed in place. And then, they had a welcome mini party for me, had a lunch. This is me down here with Professor Jin-Soo Park. And then for the training centers, I stayed mostly at Kyongbu National University. But I had the opportunity of visiting other facilities. At Kyongbu National University, they do mainly on colorectal cancers and surgeries for colorectal cancers, and less of the benign colorectal cases like hemorrhoids, pelvic floor, and the others, IBD. So Professor Jin-Soo Park had to make arrangement for me to visit other centers. So I visited the Catholic University of Korea, where our speaker for today works. And I really had a very good experience there. I also got to see how to do ultrasonography for many patients. Then I also went to Ku Hospital and then the popular Asa Medical Hospital in Seoul, courtesy of sponsorship from Professor Jin-Soo Park. My traveling expenses, the hotel where I stayed all through those days. I stayed in Asa Medical Hospital for 8 days, and at Professor Lina's hospital, I stayed in Suwon for about 10 days. This was all sponsored for. But this is Kyongbu National University, Chibok Hospital, where I stayed for 6 months. It's a tertiary center, very popular when it comes to study for colorectal cancers. They have a lot of faculties there that are well skilled in mostly minimal access surgeries, robotic, laparoscopic. They actually do a bit more of robotic surgery than laparoscopic surgeries. They also do open surgeries very occasionally, but by default, every surgery is started minimal access first, and then if there are challenges in those very few times, they'll convert to open surgery. And then to the right lower hand corner here is the colorectal surgery laboratory, where they run labs for research, colorectal research, and then where they also have postgraduate students doing PhD in colorectal surgery also go. That is also where we had offices for international fellows. I actually had my own slot there. But this is just to show the trainers that I learned from in Korea at the Kyongpoong National University, Chibok Hospital. This is Professor Choi, is a very popular minimal access surgeon in the whole of Asia. For the first time, I saw someone that was said to have learned laparoscopic surgery de novo. He actually trained himself. He trained almost all the surgeons in Korea and even beyond Korea. He trained them in laparoscopic surgery and is quite skilled when it comes to laparoscopic and robotic surgery. And then this is Jinseo Park that sponsored most of my stay in Korea. Professor Ha-Jin Kim, Professor Song Min-hyo, all the way down to Professor Song and Song Hee. This is the fellow, Dr. Soo Jin. She just finished her fellowship. Fellowship in Korea in colorectal surgery is 2 to 3 years. So she just finished hers last month. The St. Vincent Hospital, where our speaker works, is also a very big hospital owned by the Catholic Church, but very efficient place. They do a mix of different cases, not just colorectal cancer cases. They also do the benign ones, hernias, just like more like a general surgery kind of setup. But they do more advanced things in colorectal surgery. Then I went to Crew Hospital, where we saw a number of benign cases, mainly surgery for hemorrhoid. This hospital was owned by this professor here, Professor Ku. I saw surgeries under spinal anesthesia. Patient has music playing. The attendance to patients, the type of care they give to patients, and of course the variety of cases also had there. As a medical, as we all know, is among the top 25 best hospitals in the world. They are very popular for transplant-related surgeries, especially for live donor liver transplantation, but also very good in colorectal surgery. This is Professor Inja Park. She's the head of colorectal surgery unit and the current editor-in-chief of the of coloproctology. That's the official journal of the Korean Society for Coloproctology. I had a very good experience over a 10-day period. Again, very good colorectal, robotic colorectal surgery. And then then I started participating, and at times I was allowed to do a few things on that supervision. We had the labs, the wet labs, the dry labs, then through them imaging. Initially, it was more like observation. I had my own screen where I could, watch the procedures as they are going on. The data, they have so many monitors where one can actually follow. And then occasionally I was allowed to look into the console just to have a clearer view of what the surgeon was seeing. This is Professor Jinseo Park here, with me assisting him in one of the laparoscopic surgeries. And then we also involved in specimen processing after surgery. They actually have a very detailed and extensive processing of specimen using the Japanese system of arranging specimen before histology. And then I had very few exposure to robotic surgery in terms of assisting. And I was also allowed to, perform under supervision, medial and lateral mobilization for both left and right minimal access colorectal surgery. For the labs, the dry labs, I had my own corner in the lab where I could read and then have the laparoscopic trainer where I could practice suturing and a number of things. And then during the numerous conferences I was able to attend while I was in Korea, I think I attended like 3 or 4. Each of those conferences, they had this laparoscopic mannequin for young surgeons and students to lay their hands on and practice. I also had the opportunity to practice with the robotic console. The wet lab, Professor Jason Park sponsored me to St. Mary's Hospital in Seoul to, practice laparoscopic IMA ligation, median lateral mobilization, and of course TME using cadaver. And that was really quite an interesting experience for me, having to do those things myself. In terms of academic exposures, like I mentioned, the conferences, all the conferences that happened in Korea while I was there, I was sponsored by Professor Jason Park, to attend and paid for my hotel bills or the ICRS conference, the ACKSS conference, and of course the robotic camp that happened later in the year. And I was privileged to make a presentation, submit 2 abstracts during the ACKSS conference, and also got an award for that. We had some lectures by Professor Choi, he's the head of colorectal surgery at Kyungpyo Hospital. So myself and other fellows, this is Luis from Colombia and Maria from the Philippines. So we had occasional lectures with him on topics in colorectal surgery aside the weekly academic meetings on Monday. In terms of relaxation and social life in Korea, when it comes to food, in Korea, you eat and get tired. So I had a lot of lunch and dinner. I remember when the president was telling us after he went to Korea that at some point he got tired. And this was exactly my experience. They will make sure they feed you till you are tired of eating. So I had a lot of experience, a lot of outing. Most times we finish procedures by 10 p.m., 11. You still have somewhere to go and stay till like 1 a.m. at times, 12:30. A number of places. This was when I went to Assam Medical. This is Professor India Park. And then we also had the opportunity to meet Rodrigo from Brazil, very popular colorectal surgeon when he visited Korea. And then, a number of other outings. I went to see sites in Korea, Bhutan. I interacted with other colorectal surgery fellows from Philippines, from Oman, and then also had time to go to church and interact with my church people too. So in terms of the challenges I experienced, I would say that the one that is very outstanding is insufficient information. Because while I was preparing, there are a lot of things that were not very clear in terms of how much food do I need to go, like foodstuffs I need to go with, clothing, devices, what's the schedule like? All those things was till I got there that I, had the whole information. Maybe I should have asked, but I was too concerned with getting visa and sorting out the accommodation issues. But this actually, like I went to Korea with some clothes that I never wore. And while I was coming back, it was difficult packing things. And then for food, I found it difficult initially. The first 2 weeks, with Korean food, some of the food are mostly raw and all. But with time, of course, I adjusted. The problem with jet lag was also there for about a week or so. And then the fact that Korea is 8 hours away from Nigeria. So at times when I'm supposed to be sleeping, that's when my Nigerian family and friends are waking up, and at times people call me. So most times it's difficult to really get a rest or differentiate between night and day while I was there. And then there was a challenge with how much I could do. I'm very grateful to a number of my teachers and seniors that also contacted me, like Dr. Oke, asking me how I was doing and what am I doing now, or how is the program going. I remember people asking me, what can you do now? So the issue is that in Korea, there has been some change in their policy such that for international fellows, there is a limit to what you can do because of qualification and some issues since after the COVID. So I would really consider myself lucky that I was able to get some hands-on to do a few things while I was there. But looking at comparison of Korean colorectal surgery practice and Nigeria, I would say that in Korea, they have standard operating procedures for everything, every single thing. From the time I got there, every Friday I get a mail containing all the cases that it, and in 98% of the cases, they kept to that schedule. Of course, outside emergencies. So training of both their local fellows and international fellows, everything is organized. You are told when you're supposed to go for MDTs and the location, and they don't assume you know. So they give you specific information, they give you reminders. The procedures are almost the same, just with minor institutional differences. And even for their non-physician staff, like the nurses are trained in such a way that when you have a new nurse, the person starts with observation, and someone is there to monitor her, maybe for like 2 weeks, and the person starts showing her step by step what they need to do, where you need to stand. So the efficiency with which they work amazed me the very first week. The surgeon doesn't talk. The surgeon just moves his hand and they give him what he needs. And everything just looks like they've rehearsed it 1 million times. But I think it has to do with the kind of training they gave themselves. They also have, adequate human and material resources. Mostly they use single-use devices, nothing like reuse and reprocess. Most things they take new from the package. They also had alternative devices for the staplers. So if one is not working right there, they pull out another one. They have multiples of these things in the operating room. And, they have very good health insurance system where something like laparoscopic surgery is under health insurance, is covered. It's only robotic surgery that the health insurance doesn't cover. And then, they have good welfare package. The doctors are paid well, the nurses are paid well. So most times they are not really in a hurry to leave their country. So you see them very hardworking, they are patriotic, and they are dedicated. And that contributed to the efficiency of their services. So they also have this good collaboration amongst themselves. So in that hospital, for example, they have the colorectal surgeons themselves, they have their regular meetings, and then they have this wider meeting where they have the general surgeons, that's breast, GI, colorectal surgeons, come together and have academic meetings and discussions. And then, of course, the affiliation with the oncologists, the radiologists for MDT, just like we do in Nigeria, but they do these things regularly. And for example, in Kyongpu Unitarian University, the surgeon doesn't do colonoscopy or upper endoscopy, it's the gastroenterologist. Everybody just super specializes and focuses on what they are doing, and that makes them to be very good at it. They also have institutional, institutional organizations such that you have, for example, the Korean Surgical Society, you have research groups for IBD, research groups for endoscopy, research groups for robotic surgery, and they invest a lot in training and maintenance of these groups. I've talked about super specialization, so this gives them higher volumes and better outcomes. And then there is a lot of support from the government in terms of funding and then supervision. So, lessons learned, and if I may make recommendations, that first we need to have an efficient and effective leadership in the Nigerian societies that we have, both NSCRD, both SON, all these societies, we need to have effective leadership that is supported, fully supported, because most times if the leadership is doing their best, as our present leadership is doing, and you don't have adequate support by all, we won't be able to make much headway. For example, we know the president has mentioned something about the MOU between the Nigerian Society for Colorectal Disorders and the Korean Society for Colorectal in terms of and good quality research work should start coming from Nigeria, from our society to that journal, right? So if we're also not contributing papers to them, they are willing, and they've started training us through the fellowship route, for example. You find out that it will be like a one-sided kind of partnership or relationship, and that doesn't help us. So we will need to support the leadership to be able to engage and collaborate more with the international societies to get more benefits for our members. We need to standardize our practice in Nigeria. Thankfully, the present leadership of the NSCRD is working on this, and our guideline committee is also working to make this a reality. If we can have audits of what we do through conferences and symposia, it will also help us, because in those during those occasions, we can discuss what we are doing, we can question what we are doing, and we can make recommendations for ourselves. It is high time we started fellowship in colorectal surgery in Nigeria. I'm not sure how this can happen, but we can start with baby steps. We can involve the colleges, West African College of Surgeons, the National Postgraduate Medical College. We know that our neighbor here at Ghana, as of 2 years ago, when one of the general surgeons presented to us, he told us that they already started fellowship in colorectal surgery, and they had trained one person. So in Nigeria, we have both human resources and the connections actually to local and international faculties to start this. And it is something that we should look at and start as soon as possible. We need to increase our collaboration with other non-medical fields, like the biomedical engineers. Most of the things that they use in Korea are made in Korea, from the bolsters, from the stirrups, and each day. Before now, they were dependent on Japan for most things that they needed. But with time, you see that they are beginning to produce most things locally, especially the ones they use in colorectal surgery. Then we also need to increase our participation and investment in research. So I've talked about that mutually beneficial collaboration with the KSCP, for example. We need to start small, assign responsibilities, outline what we need to do, and then keep taking steps, one step at a go. I would say that my experience in Korea was a very good one and rewarding one. It was a bit tough at the very first week because of diet, because of the weather, jet lag, and all. And I wasn't too happy about the fact that I was observing most of the time. But as time went on, I had the opportunity to have at least a fair exposure to procedures. And this was Professor Choi giving me the certificate of training on the last day of my stay in Korea. I want to express my gratitude to the NSCRD for getting this opportunity for me to go to Korea. I'm thankful to my family for allowing me, be away for this length of time. It was a very long time and was quite challenging. I'm very grateful to Professor Rabo for helping me with signing all the papers and documents and the reference letters. And more importantly, to my hospital that allowed me to go. And they were also supporting me financially throughout my stay there. Thank you so much for the privilege to represent us and to make this presentation.
Thank you, Dr. Olasi, for this report. It's been very comprehensive, and I must say that we are extremely proud of you and your achievement. Again, before I open the floor for comments and questions, I just want to say that what you presented is part of the vision I had for this aspect of our society when I went to Korea in 2025. The plan in 2024, the plan was that we should have a platform where we can improve capacity and expand our horizons, and to be translatable and well meaningful. And like I said earlier at the beginning, I wanted to be in 3 categories: for the young surgeons, for the female surgeons, and for the established surgeons, or not just surgeons, members of the society. And thank you for at least manifesting this vision and also showing us some areas which we can work on. And again, I'm sorry that we put you through it. I remember telling you that you are going to be our test case so that we can understand the system and know how to progress so that we don't make the mistakes. So I know that you were some kind of a guinea pig, but at least you were able to surmount the obstacles and at least were able to get a result. So thank you once again. So I want to open the floor to comments.
Thank you so much.
I want to open the floor to comments and questions. for those who are online. You could use the raise hand function in the chat so that you can recognize, or you could just unmute yourself and speak. So while we're waiting for comments and questions, I just want to say that we're really trying to turbocharge the Scholarship and Welfare Committee. I was just waiting for Dr. Lassie's feedback so that we can understand the process better, so that we can be more efficient in it. So the experts already drafted a template of the membership of that committee that will handle scholarships and fellowships. And already we have that connect with different societies that are willing to improve our capacity. So at least now that we have this template of result reports, we can now at least progress with that. So are there any comments or questions? I know the day is fast spent. Any questions or comments? Any comment?
Mr. President, sir.
Yes, please.
So just to add that, so in Korea, they are actually very eager to train Nigerians, and it's not just Nigerians. I think I was the first international fellow from Africa that was coming over there for this training. There are a lot of people from India, Philippines, just the Asian continent that go on a very regular basis.
Yeah.
So they are for sure quite interested in having some more people come over just to engage them more and see how we too can contribute something, and not just that we are coming to take and we are not giving something back in return.
I agree perfectly, because when I went to Korea and I saw the setup and I saw people coming from all over the world, in fact, one of the top robotic surgeons in the world, and he's the leading expert in robotic surgery in the UK, Professor Jim Khan, he goes there regularly to refresh himself. So there must be something different that those guys are doing that the world is aware of. And that's why I felt that members of our society should be able to at least key into this and tap into it. And of course, we already have that understanding that people who will be coming from Nigeria would have to come through our society so that we can have that vetting process, because we don't want to send someone over there who will not represent us properly. So definitely what you said is very important. We also have to engage them too. And like you said, it should be a bi-directional interaction, not just in one direction. Already we are putting together the draft of some papers you can submit to the journal, at least as our own contribution to that relationship, so that at least they know that we're not just there to feed off of them, but also trying to compete. Yeah. So and then engage with them. So definitely that is in the pipeline. I already have that draft completed, just to make people have a look at it and sign off on it before we submit it. So I think definitely it's been a very good engagement. So if there are no more comments or questions, I just have a brief announcement that our next meeting will be the last Sunday of March as usual. To the best of my knowledge, I think it's supposed to be Professor Shino who will be talking about diverticulosis and in the colorectal sphere. We'll confirm that topic in due course and send out appropriate notice in time. But I'd like to thank us once again for being part of this meeting and for staying behind until the end. Very grateful for everybody for joining, and thank you once again for your support. I'd like to wish us a happy week ahead. Thank you.
Thank you so much, sir.
Thank
Bye,
you.
everyone.